Welcome, guys, for our 2023 edition of the Urology Viva training recordings. And before starting the recording, today we are going to discuss the topics and exam scenarios on benign prostatic hypertrophy. Before heading to the actual scenarios, you both have any questions, anything burning, or anything you want to clarify before the questions? Both of you?
Uh, no.
No? Okay, good. So we'll start the scenario. The time starts now. Good. You have a 48-year-old gentleman presenting with history of a significant difficulty in passing urine. He says that he needs to strain to pass urine and the urine stream is not brilliant. How are you going to evaluate him?
I would like to see him in my LUTS clinic, along with a bladder diary, a completed IPSS, and a urine dipstick test. I would take a focused history and a detailed examination, focusing particularly on his symptoms regarding the onset and duration. I would clarify regarding his storage and voiding symptoms, of which this seems more like a voiding symptoms, so with straining and poor flow. I would also inquire about any mixed symptoms. I would inquire about any red flag features such as visible hematuria, dysuria, weight loss, or recurrent UTI. I would also inquire about this gentleman regarding any bowel symptoms, any constipation, and his average fluid intake during the day, paying particular focus to caffeine intake and carbonated products. I would also inquire about any previous pelvic surgery or radiotherapy and past medical history, including anticoagulations or further comorbidities, or any previous medications or treatments that he's had for his urinary symptoms. I would move on to the examination, and within that, I would calculate a height and weight so that I could calculate a BMI. I would then move on to the abdominal examination, looking for any scars, any masses, and looking otherwise for any evidence of renal disease or stigmata of renal disease. And I would look at his external genitalia and evidence of phimosis or retraction in the external urethral meatus. With verbal consent and a chaperone present, I would carry out a digital rectal examination, feeling for the consistency and the size of his prostate, and also carry out a neurological examination of the lower limbs. And if his bladder is quite full, I would also like to attain a uroflowmetry test with a post-void residual if possible in clinic.
Okay, good. So his symptoms, as I said, was quite bothersome, and he was not full enough to have any uroflowmetry in that hospital visit or clinic visit. Examination wise, he's moderately built. Abdomen and external genitalia were normal. Digital rectal examination showed approximately 60 cc smooth feeling prostate. What will be your next steps?
Um, I would counsel the patient accordingly with regards to what he would want out of his symptoms, which are bothersome. I would say that there are a few options which are available regarding either conservative management, cutting down on his caffeine intake, etc., avoiding excessive water during the night, or medical treatment for his condition, which would be in the form of either an alpha blocker agent or 5-alpha reductase or a combination of both. And certainly, given his prostate size, which is around 60 cc, certain surgical options would be available. Um, Given this gentleman is relatively young, I would probably like to counsel him for alpha blocker treatment initially, and then review his symptoms in 4 to 6 weeks and see how he is getting on.
Okay, any investigations you need to do?
I would like to do the uroflowmetry test to confirm things. I may wish to do a PSA test, given the fact that he is having some dysuria symptoms, and it can help in evaluating further treatment options as per the NICE guidelines.
What is the role for PSA test?
PSA of greater than 1.4 has been shown to have an increased risk of developing acute urinary retention. And so therefore, if his PSA is indeed above this figure, then justification for medical management would be an option for this man.
What is the value? Can you repeat again?
1.4
Okay.
or above.
Yeah. Any other investigations or is it enough?
If I thought that this is pointing towards a neurological symptoms, or there was any mixed symptoms present, and he has previously had failed any further treatments, then certainly urodynamic assessment could be appropriate with regards to further planning of treatment.
What do you know about the embryology of prostate development?
So the prostate develops within the mesonephric duct. It has different zones. It has a central zone, which is derived from paramesonephric duct, and it has a peripheral zone and a transition zone, which are derived from the urogenital sinus. It sits just under the bladder, and as over time it increases in terms of hypertrophy of the glandular components of the prostate, which can lead to urinary symptoms.
Okay. In the exam, you may be asked to draw the anatomy of the prostate. Here, you can verbally explain to me if it is asked, what will you do? What is your main crux in the drawing?
I'm sorry, I didn't quite
No,
follow that.
in the exam, they may ask you to draw the prostate anatomy in a paper.
Sure.
So, if it's in here, we can't demonstrate it, but can you explain what you will draw?
So I will draw the different zones of the prostate as delineated by McNeil: peripheral zone, transition zone, central zone, and elements of the transition zone, which will have the prostatic urethra within it, a peripheral zone, which will have,
I'm trying to open a whiteboard. Do you want to draw for me? Is it just give a try? If it's not working, that's fine.
Sure.
I know in exam you can draw this much better than usually with a whiteboard.
So the prostate is here,
Mm-hmm.
and then this is the urethra going through it.
Mm-hmm.
Around the periurethral area will be the transition zone.
Mm-hmm.
Around that, sorry.
That's okay. That's okay. I understand that.
Around that will be the central.
Yeah.
And the outermost would be the peripheral zone with the anterior fibromuscular stroma as well. The central zone would also harbor the ejaculatory ducts and sort of the ejaculatory mechanisms along here, along its path.
Okay, that's good. Now, what do you know about Hall's ring? Hall, H-A-L-D, Hall's ring.
It is a combination of bladder outlet obstruction, lower urinary tract symptoms, and elements of BPH, which can merge within each other and have a component which is contributing to the lower urinary tract symptoms of bladder outlet obstruction.
Okay. What about IPS score? When you will do, what is the role in the initial evaluation?
So the IPS score has storage and voiding symptoms or questions. Within the storage symptoms, frequency, urgency, and nocturia are asked, and this is over a period of 4 weeks, and it's out of 5. And the voiding symptoms, of which there are 4, which is weakness in the stream, intermittency, hesitancy, and straining. The scoring is out of 35 with a separate quality of life questionnaire out of 6. And it's calculated according to different values and graded accordingly to the symptoms. Between 0 to 7 is mild, 8 to 19 is moderate, and 20 to 35 is severe. And it's usually a representation of the patient's symptoms over a 4-week period.
Okay, what are the limitations of IPSS scoring?
The limitations are there are 4 components addressing the voiding symptoms and only 3 addressing the storage symptoms. Therefore, it's not representative totally between equal symptom scorings. There can be, it's a very subjective assessment of the patient's reporting. So therefore, it can vary with someone having a very high objectivity of obstruction with very low symptoms, or equally the opposite, with low objectivity of symptoms but low objectivity of obstruction but high symptom score. So it's very subjective in terms of its reporting, but it's very good to use as a reference point for each patient rather than used in isolation within one consultation itself. So it is probably better to use it as a reference point to see how a treatment has benefited a particular patient.
Okay, good. Your time just completed in the midway of the last answer, but as I said, it's better to complete the answer so that it's good for people or revising, etc. Now, a good performance, I think the first time we are discussing, so you may get much more better sleek in the vocabulary and presentation, everything as we go on. Only few things here and there. For example, in the red flag sign, I think it is useful if you include the neurological signs, if at all, if there is anything, and also bedwetting. You said about hematuria, but bedwetting could be sometimes the starting point of finding something like high pressure chronic retention, overflow incontinence, renal failure. The whole thing may head into a different wrong direction. And in urology, especially in patients with urinary symptoms, either male or female, it's nice if your nursing staff can do the blood pressure and heart rate outside. So you can say that when the patient is waiting, my booking nursing staff will do the heart rate and blood pressure, because the increase in blood pressure could be secondary to the renal failure, etc. Most of the clinics do. So if you're doing in your practice, you should say. If not, also it's nice to bring in. Okay. And the other things are like IPSS score. I'm quite surprised that you have not brought it yourself in the initial summary. So bring IPSS quite early in the discussion of the signs and symptoms itself. And the easy way to remember is the moderate symptom IPSS is 8 to 19. So anything less than that is low, anything more than that is severe symptom. That's one way of remembering. Otherwise, I'm happy with the way by which you explained the IPSS, but it's nice if you have brought it in your presentation itself. And as you said, IPSS is not a very brilliant test, especially if it's done at one point, but it's nice to see the trend. I think that's what you're trying to explain. Instead of saying as a reference point, IPSS scoring, the trend will be more useful to see whether the patient is responding to our intervention or not.
Yes.
And yeah, uroflowmetry and frequency volume chart, all those things I think you have done well. Bladder diary, if possible, if it's in a one-stop clinic, you can bring some new latest concepts. As you know, from the GRIFT guidelines, there's a lot of stress on lots of one-stop clinic. And also we have got kind of a clinic setups of faster, efficient, early diagnosis symptoms which are going on. So there is a lot of push towards one-stop clinic. So you can use it for like a patient with increased PSA, one-stop testicular malignancy clinics, one-stop LUTS clinics, and one-stop female urology clinic, etc. So you can bring them. PSA, as you said, that's one of the useful tests. And when you're saying, especially if the examiner is asking, will you do any other test? The examiner is just testing you. So you need to say that no, there is no need for any other blood test. And the blood test, like for example serum creatinine or EGFR, will be useful only if there is any signs of renal failure. Similarly, imaging of upper tract is useful only if there is any signs of renal failure. and you can be a little bit more sleek in embryology. So as I said, usually all these questions are like open book exam. If you get evaluation of male LUTS in the exam, this is the exact question they are going to ask. So embryology, just be comfortable in finishing the whole thing in 3 to 4 sentences. If you just practice, you will be fine. And similarly, the imaging, as I said, is only if there is any signs of renal failure for upper tract imaging. So when the examiner is asking, instead of saying I don't need any further results or imaging, you can bring in your more caliber. As much as possible, you should show to the examiner that you know stuffs. That's the main idea of the 10 minutes. And similarly, you can bring in cystoscopy and tell that cystoscopy has a role, especially if there is a previous failed intervention, and in the modern era with multiple minimally invasive surgical treatment options available, cystoscopy will give us a good idea about the prostate's internal anatomy, which will help us to decide which type of minimally invasive treatment patient may be suitable for. Okay.
Sure.
Good.
Sure.